Good evening. I'd like to thank everyone for coming this evening here to the University of Missouri and the Missouri Orthopedic Institute. My name is Jim Keeney. I'm the head of the hip and knee service here, and Ben Hansen is with me. Dr. Ben Hansen is another one of our hip and knee reconstruction surgeons, and tonight we are going to spend a little time talking with you about partial knee replacement. So I'm going to turn the mic over to Ben, and he's going to get us started here. Thanks.
All right. Thank you, Jim. Okay, so partial knee replacement, what is it all about? So basically, we're going to start with just some background information about the knee joint, and some basic anatomy so that you'll understand when we talk about partial versus total knee replacement and the different parts of the knee. It'll hopefully make a little bit more sense. When we talk about the knee joint, we refer to it as three main parts. The inside part, which is we call the medial compartment of the knee. There's the outside part, or the lateral compartment of the knee. And then there's the patellofemoral compartment, which is the part of the knee underneath the kneecap. Okay, so there's the medial, lateral, and patellofemoral compartment of the knee. Okay? So we talk about single compartment disease. About 60 to 70% of the knees that develop arthritis will be most severe in only one of the three compartments. You could have evidence or arthritis in all three compartments, but on the most of the time, there's one compartment of the knee is more severely affected. Okay, so this bottom picture shows the inner side being more affected. This one shows the outer side or the lateral compartment, and then this picture shows the patellofemoral compartment being more affected. And it's not uncommon to see one compartment of the knee being more affected than the other. Okay? We're going to talk a little bit about the different options. So what do we do if you only have arthritis in one compartment of the knee and not that bad in the other compartments of the knee? The starting point for all of this is non-surgical treatment. Person comes in to see one of us, and they have noticeable arthritis in one or more compartments of their knee. We always review and start with what non-operative treatment has been done and what has not been done before we consider any type of surgical or replacement options. It's very important to make sure that all of the non-operative treatment has been attempted. Okay, so what are those non-operative treatment options? The main one that we use is non-steroidal anti-inflammatory medications. These are medications like ibuprofen or Aleve or Celebrex or meloxicam. There's a whole family of these type of medications. Pain medications like Tylenol can be very effective for arthritis. And then hopefully we haven't started these narcotic pain medications for arthritis pain at this point. I would really like to avoid those types of medications for arthritis pain. These are the odones, the oxycodones, the hydrocodones type medications. Okay. We're going to talk about the other treatment options. So the other treatment options are physical therapy. Keeping the muscles around the joint strong can help to stabilize the joint and can make the joint feel better. Stretching, keeping the muscles loose, avoiding contractures and tightness, all the weakness of the muscles, deconditioning, and muscle imbalance and tightness around a joint can lead to pain and the joint not working very well. So we work with a therapist on range of motion and strengthening. Getting into a pool can be beneficial. And then there's the injections, steroid injections, like cortisone type injections can be attempted. These are in order of expense, right? So hyaluronic acid injections can be given. These are best way to think about these type of injections are lubrication for the joint. Okay, hyaluronic acid is a substance that's found in the knee, and we can inject that substance to try and supplement the fluid to make it hopefully make the knee feel better. Platelet-rich plasma is also another option. I personally don't do a lot of those types of injections, and Some other physicians will maybe marketing a stem cell type injection into the knee, but it's important to realize that they're not truly stem cells. And we can talk a little bit more about that if you have questions about that at the end. In my hands, when I will offer a steroid injection, and then if somebody's got bone-on-bone arthritis, I stop there. I don't think the injections at that point are going to be much of use. We might try one steroid injection and then stop there. So, and then once those non-operative treatments have been exhausted, if the knee joint is not bone-on-bone, then there's a possibility that some of the pain may be coming from a meniscus tear. The meniscus, this is the meniscus here. On the inside, there's one on the inside part of the knee, the medial meniscus, and there's one on the outside part of the knee, the lateral meniscus. I think of those as shock absorbers in the knee. It's probably the best way to think about that. They're little C-shaped pieces of cartilage. And if you have a tear in the meniscus, that can cause mechanical symptoms of pain, catching, locking, and those can be effectively treated. Pain from a meniscus tear can be effectively treated with knee arthroscopy. We can go in and we can take out that tear, and the knee can feel markedly better. So that's an option for people if they have some arthritis, they're not bone-on-bone, and they have pain that we think is coming from a meniscus tear. Mechanical symptoms of catching, popping, locking are the people that respond best to that type of treatment. So that's something that we think about. Now, this shows another surgical option would be to realign the knee. If we have a crooked knee, right? So this is we call this a varus knee or a bow-legged knee. If a knee like this, somebody with a knee like this, when they walk and bear weight, they bear weight more through the inside part of the knee, the medial compartment. So a surgery, an osteotomy, means to cut the bone. Okay, that can be done. And so you take the knee here with that varus or the bow-legged alignment, and you do an osteotomy, or you cut the lower bone, the tibia, and you open up the inside part of it, and that realigns that knee joint. So the weight-bearing surface is no longer coming down through the medial part of the knee. It's now coming down more through the center of the knee, and that can definitely make the knee feel better in some cases if the arthritis isn't too bad. So that's an option, and there are definitely surgeons here that do that. And then now we're going to talk about what are the replacement options, okay? What do we do if we have arthritis in just one compartment of the knee or more than one compartment of the knee, the partial knee replacement options and the total knee replacement options? And Dr. Keeney's going to talk about those.
So I'm going to get through a few more slides before I dive into this one. So this is showing what a partial knee replacement is. If you see this, you can tell that there's one part of the knee that's been replaced. Even with single compartment disease, sometimes we make decisions to replace the entire knee. We can talk about that a little bit more with questions if you have them. But if there are other parts of the knee that are symptomatic, so if you have pain in the front part of the knee, or you're climbing stairs and it hurts behind your kneecap, and we have grinding and pretty prominent mechanical symptoms, we don't want to have something that causes pain down the road that we didn't address at the time of the first surgery. I want to touch a little bit on a concept of minimally invasive knee replacement. Some of you may have heard these terms, whether it was from the knee or the hip. Minimally, or maybe even trauma surgery, but minimally invasive is just a concept that says we want to try to disrupt the muscles less when we do surgery. It's less the size of the incision. It's a little bit more about what we do. So if you look at this here, the muscle up here is your quadricep muscle. So there's an inner part over here, and then you have the rectus, which is the central portion, and a tendon here, and then you have the outer part of the muscle here. This is what's called a subvastus, or a below the big muscle approach. So what we're doing is kind of coming down here, and then we're lifting the entire muscle in the kneecap out to the side. If you do a traditional approach, you actually make the incision around the kneecap and you go up in the tendon. So if you think about that, we're taking this part of the muscle and we're leaving it behind separate from the rest. So we're splitting about 2/3 of the muscle away. And just from an experience standpoint, it takes a little while for the muscle to recover after you've done that approach. It's great for seeing things, but it maybe takes a little bit longer to get a recovery back after surgery. When we think about any kind of minimally invasive procedure, the thing is that not every patient is a good candidate for a minimally invasive approach. If you have a really stiff knee, it may be difficult to expose the knee unless we kind of get things to a point where we can see and move things well. And the hardest part about this is it can be difficult or challenging for the surgeon who's doing a surgery through a smaller incision to make sure we have the rotation of the parts correct. This is most important when we're going to put the shin bone part or the tibial base plate into position. We have to turn it a little bit toward the outside, and sometimes it's hard to do that if you don't have enough of an exposure in bringing the shin bone forward. And I'd say there's some studies that are split about whether there's benefits or difficulties in people who've done this. And so, but just saying that this is a more challenging technique, I do it, but I will say it is a more challenging technique. And I was saying this problems, please see that's in quotes for a reason. I said we would look and say knee replacements, even total knee replacements, largely perform very well. But the challenge for our patients is that we replace the entire surface. It means that the components that we put in, they're large, they're not oversized. It's just that this is a complete replacement of the knee. So if you see here, we have the entire thigh bone covered, and we have the entire shin bone covered, but you don't see any cartilage that's left here that remains as a part from the patient. We have to move the kneecap out of the way, and so what you'll see is we kind of slide it over the side, and then we have to put a retractor in. So that's a metal device basically that we're using to pull the kneecap over to the side. And there's going to be some stretching of the muscle. Even if we do that low approach on the muscle, we're having to pull everything over the top. So that is some degree of trauma that will occur to the knee more with a knee replacement when it's a total replacement than a partial. And we've also seen that in knee replacements, even with modern designs, we see that there are patients who are a little bit more likely to report that their knee feels tight. And I don't mean that's a loss of movement, but it's just you kind of feel because the thickening of the tissue around the front of the knee, it just feels like it's a little more snug than it was before you had the operation. And patients who've had a total knee replacement are more likely to say, it's a little tougher for me to get out of a chair. Now, I'm going to go back and say this is traditional total knee replacement with that approach that goes up into the quad tendon. Okay, when we do that, it takes a little longer for the muscle to recover function. One of the folks that I worked with in St. Louis is named Robert Barrick. This is a paper that he published, and they had looked just at some knees that had gotten revised. It was at 3 treatment centers. There were about 237 different revisions. They just looked at them and said, why are we revising things? And they said, well, about 20% of the time the revisions were from a small incision knee replacement. 80% of the revisions are being done on conventional knee replacement surgeries. But the patients who had partial or a minimally invasive approach tended to be younger. And if you look at the time that they were revising these, it was at about 14.8 months. Rather than 80 months in a patient had a conventional knee replacement. What that means is the early revisions were largely done because components were positioned in a way that didn't make the knee work or there was instability of the knee, whereas the patients who had a traditional knee replacement and were being revised were usually being revised because of a problem with the plastic wearing over time. So different mechanisms. So they concluded that they thought that the minimally invasive procedure may be at a higher risk of problems if the surgeons putting them in weren't very attentive to how they were putting the components in. So getting into kind of partial, this is a partial replacement of the inner part of the knee, and then this is over here a replacement of the patellofemoral or the joint between the kneecap and the thigh bone. Those are probably the 2 most common forms of replacement because they're the 2 most common parts of the knee where we have isolated single compartment arthritis. You can get it on the outer side too. The usual setting where we get it on the outer side only is when somebody has torn their lateral meniscus and the knee goes bad very quickly. In most settings, when people tear their lateral meniscus, it's because of a deformity that's been long-standing, and for those patients, they also tend to have arthritis behind the kneecap as well, so it's less common that we see the lateral compartment being replaced by itself. For minimally invasive partial knee replacement, most people, we do this because most people who get arthritis will have it affecting the inner side of the knee. The other 2 parts of the knee may have more limited aging, so this is the most common way we do it. And rather than replacing the entire knee, we may be able to do something less in order to improve pain and improve function for our patients. A minimally invasive partial knee replacement will replace 1 compartment of the knee, and it preserves the normal structures. And the most important of that is this structure that you see here in this, it's a deceased person's bone and tissues, but this is the anterior cruciate ligament. So when we do a total knee replacement surgery, in order to bring the shin bone forward and be able to put a part down into that, we have to remove the anterior cruciate ligament. You guys have heard about this. This is the thing that, if a football player tears it, he can't go back to playing sports and cutting and pivoting. The other thing that's important about this ligament is it gives us a sense of what's called proprioception, or position sense. So the reason that we feel and we know what our knee is doing is because we get some feedback from some nerve endings that are in this ligament. And when the ligament's gone, the knee doesn't quite have that reporting mechanism, so you may feel a little bit that the knee just doesn't feel right. I'm not sure why, but it just doesn't feel right. So this is what we have when we have a partial knee replacement. We have a thigh bone component that you'll see up here. We have a plastic piece that sits here, and then we'll have a shin bone or a tibial tray that's down here. Now, there are two types, essentially, of partial replacements. You have ones that are what are called fixed bearings, which is where the plastic piece locks into the shin bone part of the tibial base plate. And then we have a component that's called a mobile bearing, where you have a tray that's here, and then that the plastic bearing will slide back and forth. And the reason that happens, or you have a mobile bearing, is because the shape of that implant on the thigh bone is more of a sphere or a circle, where the normal knee position is actually not perfectly spherical, but the back of the knee is. And in the mobile bearing design, they position the femoral component or thigh bone component further toward the back, and they rely on the movement through the higher arc of curvature of the back part of the femur. So when we look at minimally invasive surgery, it's easier to do this with a partial than a total knee replacement, and the reason for that is because we only need to expose a small amount of bone here on the inner part of the knee. So you can do this operation without having to go up into the muscle or the tendon at all, and to do this without stretching the tissue. Using smaller components, the kneecap stays in place. It doesn't have to be pulled off to the side, and this is truly a muscle-sparing operation. There has been tremendous growth and interest in unicompartmental or partial knee replacements over the course of the past 15 to 20 years, and partly because we've had more and more literature that's talking about how our patients who have total knee replacements aren't always happy. And we want to figure out what we can do to make knee replacement recovery better for our patients, not just for pain relief, but for long-term function. So advantages of a partial knee replacement include the shorter incision, a less invasive approach, leaving the muscle largely undisturbed. This results in a quicker recovery, an easier return to motion and function, and shorter stays in the hospital. This typically can be done now as an outpatient surgery or at most a single-day hospital stay. We see less blood loss. There's essentially no transfusions with a partial knee replacement, and very limited risks of major complications because we're not operating where the blood vessels and nerves are back behind the back of the knee at all. And this provides our patients with a more normal feeling knee. There have been studies that if they say, well, how many patients who have a partial knee replacement say that this knee feels like the knee they had before? And it's roughly about 90%. If we ask patients who have a total knee replacement, how many of them feel like it's the knee that they had before? It's about 70%. So the target when we think about doing a partial knee replacement is we want you to feel like your knee is more normal if we can make it do that. The harder part about the partial replacements, though, is that there's less margin for error, which means that if I have that whole shin bone surface to put an implant on, there's a lot of area for the bonding to occur between the implant and the bone. When you have a partial replacement, you have less of a surface for that implant to have contact, and so there's been a little higher risk for revision surgery for patients who have a partial knee replacement. You say, well, how high is that risk? So for patients who were selected pretty tightly, where they said we talked about 60 to 70% of people may be having disease mostly in one part of the knee. Most surgeons have offered partial knee replacements to about maybe 10% of the patients that they see that on an x-ray will have most of their arthritis on the inner part of the knee. And when we look at those patients having surgery, about 6 out of 100 of those would have problems compared to about 3 out of 100 who have a total knee replacement. So not a huge difference, but it's a difference. Where we see the issues with partial knee replacements are among surgeons who maybe perform fewer cases. So 12 a year, 1 a month. It's hard to keep your skill set up if you're not doing very many of them. One thing that we would say is if you have a surgeon who has done a lot of knee surgery, that tolerance may be a little bit better than if somebody who's not doing a large amount of knee replacements overall. This is one study, and I'm not trying to say anything bad about partial knee replacement. It's just saying this is a testament to how it does take some degree of frequency of use and skill set. Bill Shore wrote this up, and actually this is a confession of his own work. So he's a very good total knee replacement surgeon I know in St. Louis. This is early on in his surgical career. He probably does about 600 or 700 total knee replacements a year. And this was his early experience with a partial knee replacement. Now, this particular design was a single pegged design. The company has changed their design to 2 pegs. Partly, if you have a single peg, it's possible for the component to rotate. And so I'm not sure that all these failures are related to the surgical technique, but may have been related to the device. He had noted about a 13.5% failure rate, which is 2.5 times what we've seen in surgeons who are the masters of this technique and have reported their results. So what this was saying, this in effect was saying is maybe this risk of failure might be higher than we think. So some of it may be how we select our patients and making sure that we're doing the right thing. There is some more recent research that's looked and said that maybe we should be doing more, because surgeons who do 20% or more of their volume in partial knee replacements tend to have fewer failures than surgeons who do certainly less. This was the historical rates of failure of partial versus total, and this really looks like a big curve, but you have to remember this is 90% down here surviving, and this is 98%. So while this looks really steep, if you really drew it on a 100-point scale, this is really, really a small difference. But going out, this is 2 to 3 years. Again, the partial knee replacements with traditional older techniques had a failure rate of somewhere around 6 to 7% compared to a knee replacement conventionally done at about 2 to 3%. So that was a study from 2008. That's 10 years ago, and I think our techniques have gotten a little better. I want to talk a little bit about partial knee replacement of the kneecap joint. There probably, my experience, probably about 1 to 2% of patients who have knee arthritis will have isolated disease in their kneecap joint. And in those knees, we find that we are able to reconstruct this joint reasonably well. The thing that we have to watch out when we're surgeons doing this is that the kneecap isn't way out of position. If the kneecap's a little bit out of place, it means there's a little bit of a maltracking problem, but when we shave off the kneecap, we might release a little bit of the tissue to the side of the kneecap, and when we put the thigh bone component on, we can restore the stability reasonably well. If the kneecap is very far out of position, we may have to do other things in order to realign the kneecap rather than just relying on a replacement going in. But this is something where I would say that we would see if the knee is otherwise normal, this also gets to preserve the anterior cruciate ligament. It preserves the normal cartilage in the weight-bearing part of our knee, and this is the part of the knee that's reconstructed, so that if you have exclusively pain climbing stairs, grinding behind your kneecap, this is something that can restore pain and function fairly reliably. The designs that we have today, so these papers that I'm showing here are from designs that initially came out. I will say the designs today are more technically feasible, and they are engineered better for more reliable results when we do this operation. Older techniques here, just like older techniques with knee replacement, if we go back to 1970 and early 1980s, they were largely freehand procedures, and now what we have are better instrumented procedures that help us to be able to place these more accurately. So briefly, just kind of wrapping things up, partial knee replacement is an excellent treatment option for somewhere, I would say, between 10 and 15, maybe 10 and 20% of patients who really have isolated partial knee disease. Its advantages are smaller incision, quicker recovery, fewer major complications, and a more normal-feeling knee. And again, we have to be careful as we do our procedures to make sure we're doing them technically as well as we can to give our patients the best outcome. I think that both partial and total knee replacement, though, can be very helpful for treating the arthritis. Patients with pain that's localized to one part of the knee, I think we really need to look hard at can we make this work for our patients, because we know the function will be better and it comes a little quicker. We just want to make sure that we're not trading that off for something where you're going to have another surgery somewhere in the next 5 to 10 years rather than in 20 years. And then I think it's something valuable for our patients when they have arthritis, and you're going to talk to your doctor in the office and you say, hey, is this something I can think about? And then if so, why? And if not, what are the reasons that we might think about a total as opposed to a partial knee replacement? So with that said, I'd like to thank you all for your attention, and we would like to open for questions. I'm going to have Ben come up and both of us will kind of trade off of the mic and be glad to answer any questions you have. We also have an audience on Facebook Live, and we'd like to thank our participants there for being here, and we may field some questions from our Facebook Live participants as well. Thanks. You want to take the first?
Sure.
Anybody have a question?
Yeah.
Just paraphrase the question.
So when you talk about doing a revision, you're doing, again, a minimally invasive revision, or do you at that point end up having to go to more the standard total knee replacement?
So the question was, when we talk about doing a revision, are we then able to do a minimally invasive revision, or a minimally invasive approach, or go to a standard total knee replacement? And the answer is a standard total knee replacement. Yeah. So if somebody's had a partial knee replacement, and they're having pain now, or have had, one of those metal pieces becomes loose, or needs to be in a different position, or arthritis has developed in other parts of the knee that maybe wasn't there before, or maybe it was there just a little bit but not really symptomatic, then we would need to go and convert that to a total knee replacement. And at that point, because of the previous surgery and the scarring and the formation that has happened in the knee, it would be the standard approach without the muscle sparing part that Dr. Keeney talked about. Yeah. Other questions?
If
Yes, sir.
revision becomes a total knee replacement, is there another possibility for revision if that is not successful?
So the question is if a revision of a partial goes to a total knee replacement, is it possible to do other surgery down the road if that were to become necessary? Our hope would be that if you had a failure of a partial knee replacement, you would only need one other operation. I pulled up some of these. There's the picture back again. I'm not sure if our live audience can see this or not, but if you look, this is a partial knee replacement, and I would hope this one doesn't fail. It's actually in pretty good position. One of the things that's happened in technique, and one of the things we've seen potential issues, is if the bone from the proximal or the upper part of the shin bone, if too much bone is removed, we get down into the bone that gets softer kind of down in this area. And when we talk about converting this over to a total, a standard total knee replacement, some of that depends on, well, what happens with these implants and where they are. If the first implant was placed too deeply down into the shin bone, then when you go back in a second time, you may already be too deep in the bone to be able to really keep this as a first-time knee replacement parts, okay? But most of the time when we do this, it's going to be reconstructed with first-time implants, just like if you had a total knee replacement. And the reason is because most of these implants remove very little bone from the end of the thigh bone and the upper part of the shin bone. Does that answer that question? If we go back and that next knee replacement fails in 15 or 20 years, then that issue would be less of a concern because we still have a lot of bone still to work with then too. Our major concern about why do we not want to do second operations is because every time we do an operation, there's a risk of infection occurring for a patient. The first time you have a surgery, it's your natural body, it's your own biology, your own immune system functions well. If we go back and we do a revision when you have metal parts in your knee, the metal parts don't have the ability to fight off infection as well. So if there's a little bit of bacteria that are kind of clinging onto a part, you may not have symptoms of an infection, but it's possible for you to develop an infection with that second surgery. Or it's possible because it's a bigger surgery, it takes a longer amount of time than the first operation would have, that you might have a higher risk of having infection occur. So we'd like also for our patients not to have more than one operation if they don't need one. So what we try to work with our patients is trying to figure out what you value. What is it that you are looking for? Are you a person who says, I really want one operation and I don't ever want a second operation? You might find your surgeon more often leaning to say, well, then let's just do a total replacement. And if you say, what I'm really looking for is the best function I can get, and I'm willing to take a little bit higher risk that maybe I have to redo something in the next 10 years. But for me, the function is more important. Can I have the smaller operation? Then we would look to see that if that's an option we can work with for you.
Can I ask a question? I didn't realize this was just partial knee replacement. In 2012, the doctor I went to said, oh, you don't want a partial knee replacement because that's not going to last. And he did a total knee replacement. When he did it, put it back, he only left one blood source to my kneecap. And within 2 years, it was loose. So I came over here, and one of the surgeons here did the revision, put all new plate parts in and stuff, and he said, oh, your kneecap, you have necrosis of the kneecap. And he has me down to a little sliver of a kneecap on a metal thing, and then the little plastic tracker on it. That's been almost 3 years, and I have such pain. I don't know where to go from here. Do I go to a third one? I've tried physical therapy. He told me when I was here last May, oh, we'll just try physical therapy. That doesn't work. I did that from August until October. I tried putting a brace on my knee. I don't know where to go. I keep telling you it's the best it can be. And I'm having progressively increased chronic nerve pain. And I have my other one is bone on bone. And I dread,
Right.
I'll do anything because if my right one ends up like my left one, I will really be incapacitated.
Right. Right. Okay. Well, what do you do? I would be happy to see you in clinic and examine your knee and look at your X-rays and give you, and Dr. Keeney would too. And that's probably all that we can tell you right now, specifically without having looked specifically at your knee and specifically at your X-rays. But things can be done. Both Dr. Keeney and I help patients that have had a failed knee replacement and are on their second or their third or their fourth and have had success getting people out of pain. So I certainly wouldn't lose hope that there may be something that can be done.
The revision was done by a surgeon here.
Right.
So can I go to another surgeon?
Oh, of course. Yeah. And I would, it's always a good idea if you're unsure to get a second opinion, or if you want things explained a different way. That's perfectly fine. Mm-hmm.
But you can't replace a kneecap. Some people say when they have an artificial knee done, they have an artificial kneecap.
Yeah.
And it keeps being stressed to me, you can't have an artificial kneecap.
Yeah. No, that's good. You can keep going.
So when we resurface a kneecap, okay, so this is what you're talking about here. A portion of the kneecap has been cut off on the underside of it. So the cut was here, okay, and then a piece of plastic is cemented on underneath it. If that becomes loose, okay, another one, if there's enough bone there, another one can be re-cemented on there, okay. Now, if the kneecap starts getting too thin, okay, and it's too risky to put on another piece of plastic, then the pain, and you have a loose piece on there, sometimes just taking it out and leaving it out can help relieve the pain significantly.
But then you don't have stability in your knee.
You still can. You still can have stability in your knee. Yeah, I have had some people where I've personally operated on them, and Jim can speak for himself, where you're in a revision situation. It's the second or the third surgery that the person has had, and you get in there, and there's just not a thick enough piece of bone to put a new kneecap on. You're worried about fracture, and if you get a fracture, then that can be a bigger problem because now you can't extend your knee because the muscle's not connected to the lower bone by the kneecap. So we just leave it out, and a lot of those patients don't have pain. So.
But they walk.
And they walk. Yeah, I'll let Jim address that, his opinion.
No, I think, first of all, we're sorry you've had the issue you've had with your knee. The hard part, you're talking about one of those circumstances that it's difficult as a patient, and even for us as surgeons, it's difficult to understand and know the right answers. There are probably about 2 or 3 different things can be done if a patella is too thin. When we're talking about could you do something if that implant's not well fixed, could you do something with it? The second thing is there are some people who do bone grafting procedures to put bone back into a kneecap if it's gotten to be too thin. The thing is you have to capture the bone graft into it. It's going to take a while for bone to heal before you could potentially consider doing something else with it. The kneecap is really, it's a fulcrum if you think about what's our kneecap there for. It's got cartilage on it. But our body uses that for the quad muscle to pull the knee and to power the knee out straight. And I agree with what Dr. Hansen said completely. We have patients that if they don't have a loose button, in a revision setting, if the kneecap's very thin, we remove the button as long as the demands that the person's not putting on themselves aren't too high. Walking around on a level surface does perfectly fine. Climbing stairs at a high pace might be difficult, but the daily things that we do to get around, generally you can do pretty well, even with a relatively thin kneecap. The thing that you had spoken about earlier was the loss of the blood supply. That's where it becomes a little bit more challenging if the blood supply was really lost in the knee. And again, those are things we could look at in the office and talk a little bit more about what are our options if that's a circumstance that we're working with or you're working with. Okay. Yes, sir.
How you doing?
Good to see you.
I know technology keeps moving along.
Yep.
A couple of these seminars, suppliers of appliances have come up with something to try to save the ACL, the PCL, but that has kind of fallen by the wayside. They're still trying to do something like that, so that when you do a total replacement, you don't have to sacrifice.
Yeah, that question was, are companies trying to do something to save the ACL and the PCL? So that's the front and the back, crossing ligaments in the middle portion of the knee, in order to, even with a total knee replacement. And the answer is yes. And there are a couple of designs that have come out. One was a European design that was put in probably about 20 or 25 years ago. And what they found, I mean, this was in patients who were across all age spectrums. And they said, it did fine. It did perform well. It's hard to tell a huge difference in how that knee performed versus a conventional knee replacement the same era. One company came, I'm not going to talk about the pros and the minuses. There are some technical challenges in leaving a bone island in the middle of the shin bone when you try to put in a knee replacement, a total knee replacement. One is related to issues with the actual island. And so one of the challenges that the surgeons who were involved in the fielding of that knee replacement were finding was that about somewhere around 5% or 7% of the cases, the bone island got a fracture in the area where the ACL was done. And it's a kind of the demand of the technique. The second consideration for those of us who didn't go right into that kind of approach is that your fixation for the tibial base plate can't be quite as robust. In the early 1990s, when we started looking at base plate fixation on the tibia with a total knee replacement, what they're saying is limited fixation of the keel with pegs did not perform as well as a fully cemented keel that went down into the bone in the center. So the limitation on that approach is we get the stability from both ligaments, but the trade-off is we may not get as much fixation on the base plate, and at least and I'm speaking secondhand information and hearsay here, so we understand that some of the surgeons who were involved in putting it just found it was technically challenging for them, and they said, I'm not sure if I'm going to get that 7 to 10% better outcome that I will get from this ACL being intact for this patient versus not. Then we say, well, who needs their ACL really? I mean, we're talking, if you're going to go snow skiing with your knee, I guess you might. If you're going to play contact and cutting sports with your knee, you probably really need it. And that other thing we talked about was proprioception. Are we going to be able to maintain the proprioception of the knee? I think we probably could do that. I don't think people are going to give up hope as far as what to do, but I think we're still engineering the designs of that kind of approach and whether it's going to be able to be widely utilized instead of just a handful of expert surgeons being the only people who can really do it well.
Thanks.
Any thoughts, Ben, on that? Okay.
Yeah.
Speaking as a potential caregiver of someone getting one of these procedures, what is the difference in the at-home recuperative process for a partial versus a full knee replacement?
Generally, yeah. So the question was, if you're taking care of a loved one who has had a knee replacement, how is it different in the recovery, a partial versus a total knee replacement? And I think early on, it's easier, less painful to get around with a partial knee replacement. They'll require less help, they'll require less pain medication, and they'll be more comfortable. It's variable how long that benefit lasts, however. At some point, the total knee replacement patients are going to catch up. I think it's about, my experience has been it's a couple of weeks, and then the total knee replacement patients are catching up and are probably taking about the same amount of pain medication. But it's variable, right? I mean, people handle this trauma that we put on them differently in the way that they cope with it and deal with it. But generally speaking, it's easier recovery. Yeah. Does that answer your question?
I was wondering-
Not really, kind of.
What's the difference in the limitations of what you can do or can't do
Oh, you mean, so
after surgery?
both patients are able to walk. Okay, the partial knee replacement patient may not need the walker for as long, or may be able to go to a cane, or maybe able to walk unassisted. Both patients will be able to go up and down stairs. It might be a little slower and a little more difficult for the total knee replacement patient, but walking, going up and down stairs, both patients will be able to do. The partial knee replacement patient will just be able to do it easier and with less pain for the first week or two. Yeah. Yep.
You mentioned the fixed versus the mobile bearing. Is there a longer success rate with one kind than the other? Or do they wear longer?
So I don't think we have really great data on when you say is one better than another. And I would imagine that if we do studies, we'll say that they probably perform pretty similarly. And say, well, why does somebody use one or the other? I think it becomes largely to say, well, this is what I learned with, and this is what I like, and this is why. And what we say is we recognize with a partial knee replacement is our patients feel a lot better. It's something that recovery occurs relatively quickly if they've had it done. People who use a fixed bearing device tend to be, I would say most of us were more traditional surgeons if that was the approach that we used. So fixed bearing devices were the ones that came out first, and they were techniques that people were pretty used to. And then the mobile bearing device is one of those things where I'd say what any of these techniques is it's getting used to the positioning of the components and being able to place it where you want to. And that's the technically demanding part of this. And I would say that marketing in a lot of ways kind of came about why people chose one or the other. So I don't mean marketing in a bad way. I mean, we have colleagues and friends and people that have been involved in using a particular type of knee replacement. I got introduced to the mobile bearing knee replacement because Robert Barrick was one of my partners in St. Louis, Missouri, and he was using it. And they said, you ought to learn about this and try it. And so that's how I got involved in using a mobile bearing knee replacement in 2010. And I'd say in the United States, that's currently the most commonly used partial knee replacement. There are 2 or 3 companies that have made a fixed bearing conventional knee replacement, and then Conformis, which is another customized implant company, makes a customized partial knee replacement. The hard part is because these, from a standpoint of function, do so well, it's hard for us to tell differences between one design and another and how the early functional results are. And my perspective is that I don't have enough long-term tracking of patients for me to tell you that in 10 to 15 or 20 years it's going to be different. I'm still tracking my patients in the 7 to 10 year range right now. So, Ben, how do you think?
I answered it. Yeah, I agree. Yeah.
Is there an age limit on the minimally invasive?
No.
I mean, I know 90-year-olds have
That's the
total
easy
knee
answer.
replacement, and so there isn't any kind of an age consideration for the minimally invasive.
No, it's hard for me to say that there is an age cutoff for any of it. Yeah. I mean, it's a patient's.
If you're 80 and you get a minimal, and it's going to go out in 10 years, you're probably out before it goes out. So
Yeah. I don't see a lot of 80-year-olds that have just one part of their knee with arthritis. Generally, it's the younger people that have that. But age is not, it's hard. Yeah, I mean, the easy answer, the number itself, the answer to the question is no. The question was, is there an age cutoff for a minimally invasive knee replacement? And the answer to that is no. It's a very specific individual decision that we make in the clinic, and a number is just a number, but everybody has a different, I call it physiological age, right? And that's something that we talk about in clinic and what's best for each person individually. Yeah.
Yes, sir.
This probably sounds dumb, but I'm a mechanic, okay? So, they have ports for people who have diabetes and they have to shoot insulin and all that kind of stuff. Have they ever done any kind of, you're smiling.
I'm interested in where it's going. That's good.
Some kind of a port where you can shoot some sort of a synthetic
Yes, so-
We'll replace it.
Yeah, that's an interesting question. So you're talking about, is there a way, there are ports that we use for things like infusions of diabetes and those kind of things, or any way that we can make a port or something to inject or introduce lubricants or medications in a knee? So Dr. Hansen touched briefly on these 4 types of things that we're injecting into knee joints that have arthritis. And I'm going to talk a little bit just briefly about what they are and how, or at least my philosophy and why I think we have them. Steroid is a medication. It decreases the immune system's function. It decreases inflammatory processes. We've been using corticosteroids and injections in joints since before I was born, so probably in the early 1960s or late 1950s. And those were very effective in improving pain for a lot of people for periods of time. The limitation on those kind of medications was that over time, we would see aging of the knee joint or a joint that has arthritis. And so, well, why does that happen? Well, we learned a couple of things over the course of the past 7 or 8 years. It may be the cortisone. It may also be local anesthetics that we introduce into the knee when you do that repeatedly over time. If somebody's 30 years of age and they come in my office and see my knee hurts, I want to play professional football and I've got to go out and play my game, I would prefer not to be putting cortisone into their knee at 30 years of age. Their cartilage is young and healthy, and they're going to go out and run and do things on their knee that may damage their cartilage. And at 30, we talk about age-wise, if I put a joint replacement in a 30-year-old, that's very hard for that to be lifelong for that person because the demand they put on their joint's so high. But if somebody's at an age where a joint replacement's probably going to last 20 years or so under most circumstances, we don't think so much about are we going to wear the cartilage out by giving injections that last 3 to 4 months at a time. And so it's the least expensive cost with good benefits that are predictable in how they work. Hyaluronic acid injections came out in about the mid to late 1990s for most of us. I was introduced to them about 1997, and I think that they were a good option as they were fielded. The challenge that we're having right now is because the way the studies have been published on this type of medication, they've said, you know what, we get a little bit of benefit, but it isn't this wow, knock it out of the park. And part of the reason is because hyaluronic acid, that lubricant that you're talking about, and like that oil, it's kind of like the oil change in your knee. Arthritic fluid becomes more watery and loses the protein content. Hyaluronic acid is one of the proteins that floats around in the knee joint normally, so that injection is supposed to be restoring the biology and the nature of the knee joint. So yeah, if we could put a port in there and do that without infection developing, that'd be great. You could just come in and fill it up and be done. Our biggest concern is that with something's indwelling and going into the joint, that you might get infection. Does that make sense? But the problem that we have, if you come in with that injection today, the insurance may not cover that injection like it used to, and the cost of those is probably somewhere, the medicine's somewhere between probably 6 and about 10 times what the cost of a steroid medication is. So you might get a bill for that where we didn't before, and that's what we're going to be conscious of. We're going to check and see, can we get it approved? Ben, I'm going to ask you what your thoughts are about hyaluronic acid injections. I still think they're effective in the right setting. I think they're valuable in the right setting because when they work, they tend to last longer. But I tend to use it in earlier stages of the arthritis when it's not bone on bone, and the chances of it being effective for a longer period of time are higher.
Yeah. I agree. Our academy recommends not using them as a treatment option for patients with arthritis. I was just at a meeting where we discussed this, and pretty much all of the surgeons there admitted that they have several patients that they've treated with them who have had benefit from the hyaluronic acid injections. But I totally agree with what Dr. Keeney said. Generally, I use it in the earlier stages of arthritis. And I shy away from it if people are showing severe bone-on-bone arthritis, because I haven't found it to be of a lot of benefit when you try and balance the benefit and the cost. So I still do it, and I have a lot of patients that come back requesting it because it helps them for such a long period of time. So I agree with what he said. Do you want to address
sure.
this question here, the cost difference? Probably.
Well, which was it?
The cost difference between a partial and a total. This is just a Facebook Live question.
So Facebook Live says, what's the cost difference of a partial and a total? I would say that's going to be an interesting question, because do you see it? So it's under when we look at doing joint replacement surgery, it falls under something called a DRG payment. So the payments are set up and they're directed based on the type of procedure. So a arthroplasty surgery is an arthroplasty surgery. They fall under the same DRG. I would have to ask somebody from the hospital whether or not that translates into a minor, a little bit less charge for a partial than a total. When we look at the cost of the implants, and as a patient, you're not going to see the cost of the implant. It folds underneath the hospital's payments. My suspicion is a partial replacement is a little bit less, but not quite as much as you might think. But it's a little less material, but it's still a technology that's developed for a purpose, and it's what it is.
Great. I'm going to do just a couple more from the Facebook, and then we'll get to your question. Is that okay? So one question here was, what are your thoughts on a resurfacing versus a partial knee replacement? Those are kind of the same thing. So all of these are resurfacing. A partial knee replacement, a total knee replacement, well, that's what we're doing. We are resurfacing the end of the bones. So that's just a clarification point there. And then the next question was, what are the pros and the cons of doing bilateral total knee replacements at the same time? Do you recommend same day or within a few days? So bilateral total knee replacements at the same time can be done. And it's a patient selection, and it's a conversation that we have to have on an individual basis. It's hard to recover from two at the same time. I mean, that's pretty clear. So it's at the right patient at the right time, it can be a benefit for sure. There are plenty of happy patients that have had them done at the same time, but it's not for everybody. It's not for everybody. And maybe Jim, Dr. Keeney has more to add to that.
Yeah, so bilaterals. When I trained in the 1990s, I wouldn't have thought about doing a bilateral total knee replacement. I think part of the challenge we had was pain control, and that was the biggest thing. So we're going to do something that hurts a lot, and we're going to do it again another time, and it's going to hurt a lot even more. Over the course of probably past, again, this is about 7 to 8 years, I started doing a few bilateral procedures on patients who had very, very severe disease in both of their knees. Where you couldn't tell which one was really the bad knee. They couldn't tell me which one was the bad knee. And my first ones were done in patients who were under the age of 50. They had to go back to work. They had to get back to doing things. So taking 2 times off of work for a 2-month recovery was economically not a good idea for them. And I started doing bilateral knee replacements, so in 2008 or 9. And my experience in that time frame with what we've done with pain approaches is different than what had been a decade before. And when I observed my patients who had staged their knee replacements by 3 months, they were slower in recovery at the 4 and the 6 month period of time than if they did them both at the same time. And you'd say, well, how is that? Well, you think about it. You got 1 surgery, you got 1 recovery, you take 1 deep dip, and then by 3 months out, you have both of your knees at 3 months of recovery. If we stage them and we do them separately, well, 1 knee, you're just getting started on your recovery, so it's going to take 3 months to be at the same point. So my experience was the first 6 to 8 weeks, it's a little harder with a bilateral knee replacement. Part of this spills over to the philosophies of what do we do getting ready for the operation. So we ask our patients to participate in rehabilitation ahead of their operation. And the reason for that is so that dip that you take when you have either a single or a 2 knee replacement done, it's less of a dip. Your recovery is going to occur more smoothly and better than if we just kind of said, okay, you've got bad arthritis, you haven't walked in 6 months, let's do your knee replacement so your pain goes away so you can start walking. So we recognize that what we're asking our patients to do is a little harder on the front end to be doing some therapy when you have a knee that hurts, but it pays dividends at the end of this. So I agree with Dr. Hansen, though. It's not for everybody. The main concern that I have is if you have any heart disease, what we've seen reported in literature is your risk of heart problems after a bilateral knee replacement is the major concern. Blood clots and infection are not higher. It's the issue of can we say we can safely do this for your heart? And so my oldest patients tend to be at 70 years of age, and I have a hard time pushing much above 70.
Great. Okay. Yeah.
This may be completely wishful thinking, but is there any prevention for arthritis or reduction of arthritis to prevent what's going on here with these partial or full knee replacements?
I don't think we don't know of any way to prevent the destruction of the cartilage that then leads to bone on bone. Okay, I don't know of a way to prevent that process. We know it can be accelerated by trauma, injury, wear and tear. But certainly the advantages, the benefits of staying active and exercise outweigh the wear and tear that you're going to put on your knee. And never would I tell a patient, okay, you need to just chill out and watch TV and not move, right? Because we don't want your knee to wear out, right? Because the health benefits outweigh that for sure. But I think it's an important point. I think people that remain strong physically and stay active can tolerate more arthritis than those that don't. So if you keep your weight under control, you keep the lower extremity muscles strong, you maintain your flexibility, you might be able to go longer, and there's no question in my mind that you're going to be at less risk for complications if you end up needing the knee replacement, right, if you do those things. So I think maintaining your physical fitness and your nutritional status, stay as healthy as you can, may not prevent it ultimately, but it might delay it, and then it will help you if you end up having to have it. Does that answer your question? Okay.
Thank you.
Yeah, I'd like to acknowledge some folks who've said hello on Facebook Live. I want to say, sorry. Thanks for your comments. Appreciate it. I appreciate that. Thanks. And then I'm going to answer a question. I don't want to name people, but it's a pleasure for us to help take care of you. And I think next thing I saw was a patient who had a concern about, what do we do for infection and preventing infection after surgery. I want to talk about that a little bit. Some of that, we say it's many factors play into infection risk. If I was thinking about surgery 25 years ago, our major concern was, hey, how are the instruments being processed, and are we doing things in the hospital to prevent people from getting a hospital-acquired infection? And I think the nice thing is that we're benefiting from 30 and 40 and 50 years of infection control practices that have gotten much better. The residual concerns that we have is how do we help our patients be in the best condition to undergo a surgery with the least amount of infection risk at the time that we do our first operation. And so, first of all, we want to make sure that our patient's health is in the best shape that it can be in. We think there are 4 factors that we find that play into our infection risk the most strongly. One is if our weight and our diabetic health or blood sugar regulation isn't in the best shape. Blood sugar elevations after surgery in the first few days afterwards decrease the body's immune system's ability to fight off some bacteria that might get into their system. So when people are healthy and they have the surgery, your body will do its part, but that's one of the things that we try to work on controlling. There are some suggestions that if people are very, very heavy, they're at a higher risk, and we're talking about body mass index above 50, maybe even body mass index above 45. And so that's kind of where we're asking patients to work with us in helping to get weight down. There's another factor that has to do with the protein levels in our body and how our proteins are going around from a nutritional status, and so we're checking for our patients something called an albumin level, and if that level is not where it needs to be, we try to get you in touch with a nutritionist who can help you on how to have better protein balance in your diet and how to help your own healing potential. We haven't been as strict about smoking in our practice. There are some studies that suggest if our patients smoke, because of what nicotine does to small blood vessels, if you stop smoking for 4 weeks ahead of surgery and stop smoking for 4 weeks afterwards, that your infection risk is lower. I'm not sure that means if you go on a nicotine patch that will do the trick, because it still has the nicotine, and we don't have studies that say this. We really would like for people as much as possible to do that, but we haven't restricted that from our treatment. The other thing that we've done is, and this is a little bit controversial, if I say this around national meetings, we may get into a little bit of trouble because not everybody has the same appreciation on the use of vancomycin as an antibiotic ahead of surgery. We've been using it here as a preoperative antibiotic along with a typical, what's called a first-generation cephalosporin that's like penicillin-ish medicine. And if you're allergic to penicillins, we give you a different medicine. The combination of the medications delivered on time in our patients has an infection rate here in people who have reasonable health at 0.3% with the on-time delivery of antibiotics, which is 3-fold lower than the national average. So what we found is if the antibiotics aren't received on time, and this is historical, this is looking at our past, it's a higher risk of infection in that setting. Still, the national trend is not to use vancomycin at all. The other thing that we add into this is we clean everybody's skin with something called chlorhexidine. We have our patients clean it ahead of surgery. If you can take it in the shower and use it in the shower, that's probably the best way to do it. The other way is to use a wipe on your skin before you have the operation done. And then in the operating room, we use chlorhexidine again. There also are options where we can put something, either betadine or chlorhexidine, into the wound as a diluted lavage at the end of the procedure. And so we're doing a lot of things trying to reduce the risk of infection. And I hope that answered the question that people had. So I think we have a good approach and a relatively limited risk when we're doing all these things together. So, Ben, I don't know if you have any additional thoughts.
Another question here? Yeah.
What can you do for someone who has a scar tissue problem after total knee replacement?
Okay, so the question was, what can you do for a person that has a scar tissue problem after a knee replacement? So in the first 6 weeks or 9 weeks, okay, 6 to 8, 9 weeks, if somebody that's had a knee replacement and they develop a really stiff knee, then we can take them back to the operating room and put them to sleep and bend the knee for them. We call that a manipulation under anesthesia. And so that's something that can be done, and that generally has excellent results if you do it in that time frame. Now, if you do it after that, 3-4 months after the knee replacement, then the manipulations don't work as well. If the knee continues to be stiff, then we can go in and sometimes we can be successful with going in and cutting out some of the scar tissue and maybe making the plastic liner smaller to create more space so that the knee can bend. That's also more successful and has a better chance of working if we do it sooner. If you're a year or two out, then that usually doesn't work very well. At that point, then we'd be talking about either redoing the knee, taking everything out and redoing it, and hopefully improving the range of motion and the stiffness. However, the results for doing a revision or a redo knee replacement for stiffness alone, not for pain, for stiffness alone, if the components are in good position, is not very high. Not very good results. But usually there's an underlying cause for the stiffness. Maybe the knee's infected, maybe the components were oversized, maybe they were the balance of the knee was wrong. If we can identify the cause of the stiffness, and then the chances of improving that with the redo surgery increase significantly. So that's what we're looking for if as a physician, as a surgeon, is what's the underlying cause of this stiffness, and can we fix the underlying cause? And then the stiffness and the pain can improve. Again, it's kind of individual. Did that answer your question? It's kind of an individual decision, but things can be done. Yeah.
But touch a little bit, if you can, on how do you prevent people from getting a stiff knee? I mean, so we hope that we don't have the treated knee that's become stiff. It can happen. What do you do to try to limit the chances that a patient has a stiff knee when you do a knee replacement? So
the first thing is I'm meticulous about component positioning, component sizing, and balancing the gaps and balancing the soft tissues of the knee. So we talk about the flexion and extension gap. So the space here, okay, between the two bones when the knee is in extension, and then when the knee bends, there's also a space. And I work very hard, we both do, to balance those gaps, make them the same width, okay? And then after we put the knee in, we also look at the soft tissues around the knee and balance those. Are the soft tissues too tight on one side or too loose on the other side? And we do soft tissue releases to balance the knee. And that's probably the main thing that I do to prevent, in surgery, to prevent stiffness or problems afterwards. Now, before surgery, okay, it's very important I think it's very important to do therapy and try and improve the range of motion the best you can before, because a stiff knee before has a better chance of being a stiff knee after. Okay? It's always like, where do we start? Did this person be able to move their knee only 40 degrees? The chances of getting 120 degrees on a knee that only moved 40 preoperatively is not very good, right? So Maintaining the preoperative range of motion definitely helps with the postoperative range of motion. And then being compliant with therapy after. It's a big deal. Working with the therapist, staying in touch with the therapist, staying in touch with us. If you start having stiffness, then we can, see you and try and, sometimes the answer is no more therapy. Sometimes anti-inflammatory medications and rest. Sometimes it's, let's hit it a little harder with therapy, right? It depends on what the knee looks like, if there's a lot of swelling. So stay in touch with us after surgery, do therapy before surgery, and then we work our tail off to make sure that we do our part right.
I'm going to address another Facebook Live question, which is, do you need a doctor's referral to get in an appointment with us? I think that answer is you don't. I think you can call our phone line, which is 573-882-BONE, and that will get you an opportunity to get an appointment with us. That said, you may want to check with your insurance provider also and make sure that they don't require you to get a referral from your physician to come and see us. That's the only thing. But we would be glad for you to contact us if you would like to see any member of our team. And we have several of us, not just Dr. Hansen and I, who do knee replacement and partial knee replacement surgery. I want to briefly touch on another thing. You may or may not have heard about a program here that's called the BioJoint program or the Biological Joint Replacement program. What that procedure is similar to a joint replacement. It's an assessment of the cartilage that's damaged in the knee and essentially doing a transplant surgery for the joint. So we're taking, unfortunately, somebody who had died and they have donated their parts to different people. They may have donated their heart, their kidneys, or their liver. They may also have donated bone and cartilage. That procedure, it needs to be absolutely size specific. So if you're a patient, it's just like being on a transplant list, you're kind of waiting for that part to come in that matches your physical size. We have two of our surgeons who are performing biojoint procedures in the knee, Dr. Jim Stannard and Dr. Mauricio Cafuri. And we have one of our surgeons, Dr. Brett Christ, who is looking at that approach for the hip. And those are the main areas where we have that being done. We think that it's, as a group and as a practice, that it's a promising approach, particularly for very young patients who are not candidates for joint replacement and for patients who are going to be highly active in what their pursuits are after surgery. And so if that's something, if you're in a patient who's in your 40s or you're a patient maybe in your young 50s, maybe even up to late 50s, if you're very, very active, you say, you know what, I'm expecting I'm going to go running on my knee, I do very active things, that is a possibility in our program. I think if you call that 573-882-BONE number as well, our staff can also help you get information about that program if you have an interest.
Yeah.
Dr. Jimmy Cook used to be our dog's vet over at the hospital, and he transferred over to this Bio Institute. He always said to us, now, Sue, what I'm working on is inoculating a medium with your own meniscus, and then when it grows, it'll be a very minimally invasive, we'll just slip that in and you won't be bone on bone anymore. And I said to him, whenever you're ready to try it on people, I'm here. Is there any progress in that?
No. I'm not aware of any, Dr. Keeney, are you?
If you're talking about synthetically regenerating tissue, the answer is there's progress being made in that. It is still in the preliminary phases of development, so they're not at a point quite to put that into us yet. That said, we would hope that that's a direction things are. Some of us have very, I don't want to say creative minds, but we can see in the future and think about the future, what could be. What I'm saying is what we're looking at in those programs that are here is these are the things that could be, and we want to see if they can become possible or not. You guys understand the Thompson family, the Thompson Foundation. They have contributed to the university and have contributed to a research floor here that's in the field of regenerative medicine. And we have other individuals who have donated as well as research grant support to investigate these things. And investigations occur at the level of biology, and they occur at the level of biomechanics in the lab. Then they occur in the area of animal research, and we like animals, and we want to take good care of them and be very thoughtful about how we approach that research. But at the same point, we have to have those phases before we can go into human research. And so we've seen that in the biological joint program. And I imagine that over time we're going to see that in the regenerative medicine field as well. And I would echo Ben's. So you have to understand, we're arthroplasty surgeons. We've lived in the world of metal and plastic. We kind of know what the domain is. We know how predictable it is, and we know the limitations of that domain. For those of us who are very assured in what we do, we say, hey, we know that we've got a good product, and we know we deliver it well. We also appreciate that some of our patients have an interest in partnership and discovery and understanding if other things will work. Because hopefully, we'd say maybe the future is in 20 years or 15 years or 10 years or 50 years, we don't know. When is that other option going to be the future? So I've spoken in a broad sense, but I hope that answers your question.
Answer your question, yeah. It's not ready for prime time yet. Yeah, that's all. Yeah.
Because the osteoporosis, like in my medial side of my knees, the bow leg it starts, the bowing. And I know when you do a complete resurfacing, you can straighten some of the alignment out.
Yep.
Can you do much at all when you do a partial?
So the question was, with the bowing, can you correct the alignment with the partial? Right.
I know it can't be as extreme as it can be.
Right. So with a total knee replacement, we can, by the angle that we make this cut, okay, we can straighten out, we can correct the alignment to some degree. With a partial knee replacement, you can't really do that, okay? You're just not, because you're not getting into you're limited in your ability to, because of the restriction of the amount of bone that you remove. You're just operating on that one side. So that's one of the things, a big deformity would be a person that I would steer towards a total knee replacement instead of a partial knee replacement.
One other question, then, if I could. The CAD design replacement appliances versus the off-the-shelf, do you find much differences or benefits?
Well, I'm going to touch on some of the reason I went back to this slide so you can see this. This is a 42-year-old gentleman that I treated, and he came in with this deformity. And the challenge I had with this, if I cut this bone in order to realign it, a partial knee replacement you can't correct far enough. If I do a total knee replacement to do that, I have to cut an angle on this cut that goes from about here to here. That's going to make an unstable knee. So part of this procedure was saying, what we're going to do is this hopefully will help you in this non-replacement operation to improve your alignment and your pain level. If it doesn't, what it does is it sets me up for your next operation when I do a partial or I do a total because we got your alignment underneath you. And part of the biological approach does this as well. We work on alignment in addition to what we do with cartilage replacement surgery. So I got off track on the second question that you asked again, sir. Remind me.
CAD design appliance.
Yeah, right. So we're talking about computer-assisted design technologies and a customized approach or a assisted approach with what's called patient-specific instrumentation to put in a knee replacement as opposed to what we call as an off-the-shelf knee replacement. And what I'll tell you is that I'm in the process of kind of evaluating that. And what I'd say with this, if we talked earlier about the limitation of your replacement and the problems. What people say is there's about 15% of people who aren't really happy with the knee replacement they have. If I go to a national meeting over the past 2 or 3 years, as I've gone to them, people will say is, maybe what we're doing wrong is we're trying to put the parts in space in a place that they didn't used to be. We're trying to correct deformities and malalignment of a knee for bow leg and put components in a different position than your leg was. And your soft tissues may not like that. We typically have gone and released, like in a knee like this, we would go release the ligament on this inner side of the knee in order to bring this leg over and correct it. And so that's one of the questions that people have brought about. So the customized knee, what they're trying to do is say, we're going to take this thigh bone and we're going to figure out where the natural axis of curvature passes, and then we're going to build an implant that fits on your knee in the natural axis of your thigh bone's rotation. And then we're going to take an implant and we're going to cut the shin bone and we're going to put it at the angle that we want to. Now, what they will tell me is that this knee that you're seeing up on the board right here, it can't do it. There's too much deformity in this knee to use this with a customized knee. So if you're going to do it, it's within a certain range of deformity, usually about 10 degrees, but not talking about 15 or 20 degrees. And if I'm looking at patients, I see, maybe this is getting too big-headed, and I don't mean any of us to say that. We think that our knee replacements are all doing pretty good. And I see our patients back, we see our patients back at 4 weeks or 6 weeks out from surgery, and they're doing okay. And at 3 months, they're kind of doing okay. What I'll say is it's hard to know those long-term benefits when we're still recovering at 6 weeks and 3 months from that early phase of surgery. What I will say is that most of our patients with both off-the-shelf and with customized designs are doing very well in the way that we put in our knees and balance them. And I would say I express what Ben said. I've worked with him in the operating room, okay? I know how he's technically proficient, and he's also very much in the mind of saying, I'm going to do this exactly the way it needs to be done. We're not in a race to do this and see if I can do the 20-minute knee replacement because it's a factory. We're not going to take 5 hours to do one either, but we're going to do it in a thoughtful process that says these parts go in the way I want to. The customized knee, I talk a lot. I'm sorry, Ben. You're going to listen to this stuff. No, but the customized knee, the thing is for us is the computer is making the decision, tells me where I need to cut the implant. And then I'm going to go in and I'm going to replicate as best as I can exactly what the computer says. From a standpoint of a surgeon, we are used to being in charge of things and doing things and fixing things. And now what we've done is we've relegated that to being a technician doing an operation and not thinking much, but just doing it. And that's the hardest part for us to separate is that I sure hope this works out exactly the way the company said because some engineer sitting in Boston, Massachusetts is telling me how to put this in, whereas I'm taking all that 20 years of surgical experience and training and putting it on the back shelf. The thing about today's off-the-shelf implants, what I say is these are about fourth generation now or fifth generation designs. And most of them have not gone through phase shifts where they've jumped from one thing to the next thing. They've kind of incrementally improved the designs based on good research and biomechanics. And what I would say is most of the mechanics of how an off-the-shelf knee works today is miles ahead of the off-the-shelf knee replacement that we were putting in 20 and 30 years ago. And Jimmy Cook, I love him. I mean, and I said, he's got a great story that tells the passion of why he's gone down biological research because he has somebody he knew who had a very rough time going through multiple surgeries. We do not expect that is going to be the story for most of our patients 20 and 25 years from today, even with an off-the-shelf implant. I don't know, Ben, if that answers, but you have anything else to add to that?
No, that's good.
Thanks.
Yeah. Yes.
This is probably too specific of a question, but I forgot to ask his doctor. So he's checking out his knee, and he's got range of motion of, is it 3 degrees? Is that the right term? 3
Sure.
degrees to 115.
Okay.
What's normal?
Have you had a knee replacement? No.
No, he's bone on bone.
Yeah.
I got a question about that too. My pain is not in the knee joint, it's down here.
Yeah. Okay. So the question was,
Pain on it like trying to climb the stairs or something, or go down the stairs. That's when I can't do it. I have to go one step at a time.
all right. So the question was, what is normal knee range of motion before surgery? The patient, the person here, it says that they have 3 to 115 degrees, and then also has bone-on-bone arthritis in the knee, but has more pain down into below the knee, kind of into the shin bone,
I got a little bit on the other one also.
than in the knee.
Not as bad.
Right.
That's my business.
So, but in somebody with bone-on-bone arthritis, range of motion from 3 to 115 is pretty good. I'm pretty happy with that. Going in, I think we're going to be able to get you 115 to, when you walk on it. Yeah.
So what's normal?
So normal would be full extension, so 0, right? So 3 is 3 degrees from full extension to 130, 140 degrees.
Oh, okay.
Yeah. Okay. And then it's not uncommon for people to have pain in the shin bone that's referred down from the knee. I think that's not unusual. That's right.
The solution is a total knee replacement.
Most likely. Yeah.
Yeah, some of the issues when you talk about with the knee replacement, the average movement with a total knee replacement is somewhere around 115 to 120 degrees is about the average that we get. So that means there's some people getting 140 or 130. There are other people who are getting 90 to 100, but the bell of the curve sits right around about 118, 116 degrees. That said, what we want to do is try to improve motion if we can ahead of the operation, if we can. And there are some things that we do, and I don't know if Ben wants to get in this, but technically we talk about what we do with the ligaments in the knee. The anterior cruciate ligament's usually gone with every surgery when we do a total knee replacement. Patients who have limited movement where it's less than about 110, maybe up to 115, I'm more likely in those patients to use what's called a cruciate ligament stabilized or substituting design of knee. It just means that we take out any chance that second ligament that's in the center of the knee is a contracting force, not allowing the knee to bend as you get the arthritis. So that's just one of those things that we can do to try to help a knee that may be getting less than 115 degrees to potentially get 120 or 125 or more. I'm going to talk. There's a question that came that was asking about whether knee replacement outcomes improve mobility for patients who've had amputation. And my answer would be to that is that's. I'm sorry about your circumstance with the leg that had to have the amputation. We expect that if you have severe arthritis that's limiting your pain and your function in your non-amputated leg, that we would expect that you would get an improvement, certainly in pain, and secondarily, you would likely get an improvement in function. The one lesson that I took home, and if you're seeing a surgeon about it, I've had one patient who had an amputation on the other leg, and they required a more robust suture repair of the opening that we put into the knee because of the load that's put on the replaced knee, without being able to rely on the amputated leg as well. Even with the use of a prosthesis, you're going to place a little bit more demand on the prosthetic leg in the initial 4 to 6 weeks after surgery. So that's my one thing. I've had a few patients who've had contralateral or opposite side amputations, and they have done very well when they had their other side replaced. And what again plays into that is if you have severe arthritis on an X-ray, the chances you're going to do well are actually very, very good.
Other questions? I think we've covered it. Do you see anything else that we haven't answered?
I think we're good.
We're good.
Anything else?
All right. Well, thank you very much for your attention and for coming. And be happy to see if you have any further questions, either in the clinic setting or afterwards as well.
Thank you, Ben.
Thank you.
Thank you.